Hi, my name is Felix Rodriguez Beard. I'm gonna be talking about the first discussion of the neck and cervical spine case study. The background for the patient is a 23 years old football player. Um, this football player had previously history of 1 year recurrent stinger burners in the left upper extremity. So he's been having kind of like those type of tingling and kind of like pain sensations and numbness on the left arm for the past year. Patient reports that he was involved recently in a head collision with another player. After the head collision, patient was sent to the ER and also to the subsequent orthopedic surgery to be able to get tested for a positive Hermite signs. And patient was treated and reported with a mild concussion. Now I'm gonna be talking a little bit about all those things. The pathophysiology. So burn stingers is the result of an air traction or compression, particularly from C5 or C6, according to Mark with a reference of 2004. Um, Stinger are divided by grade 1, 2, and 3. Grade 1 is called neuropraxia. It's kind of like the most common one. Is the most common one caused by a blown or trauma into the area that causes temporary blocking to the nerves. So mainly, pretty sure I'm gonna be saying it a little bit later in the slide, but kind of like one of the most common signs with the hit to the blunt or trauma. It's kind of like from a direct blow or kind of like lateral flexion of the neck. It's kind of like the most common one, the most basic one that usually a lot of the times happens. A lot of the patients kind of like get through it, they get fine really quick. It's not very common to be able to last really long with a grade 1. A grade 2 is kind of like a more moderate into the nerves and a little bit more deeper, while the teacher's layers are still attached. So the impact means that it will be kind of like even heavier. So the impact was deeper into the area, but didn't cause any type of avulsion or tear of the nerves or either like the muscles or anything like that. And then a grade 3 that is called a pneumothesis. That is the most severe one and complete nerve severance or complete rupture of the nerve that can only be treated with surgical procedure. So that, like it says there, that will be complete tear of the area of the nerve, which can only be treated with surgical procedure. Sometimes a patient also reports discomfort, pain, or loss sensations in the brachial plexus that is going to be from C4 to C8, and sometimes also it's going to be also affecting the T1, according to Mark at 2004. Like I said before, too, the mechanism of injury, most common mechanism of injury, unilateral traction of the cervical or a direct blow in the supraclavicular fossa, so lower lateral neck, where the clavicle is kind of like more medial side and really on the inferior side. Inferior side. The target area. The target area will be kind of like those type of muscles and nerves that are gonna be affected by the injury. Muscle like is gonna be trapezius and also rhomboids, but rhomboids are gonna be mainly because of the posture. So like if the patient has some type of like rounded shoulders, frontal rounded shoulders, that means that the back muscles are gonna be stretched, that they're gonna be weakened and stuff. That's kind of like the muscles that are gonna be affected, the target area. And also the nerve roots from C4 to C8 and also T1. Um, According to Rachel from 2025, injury rate is around 65% in contact sports such as football, Canadian football, soccer, etc. So any type of contact sport that is related, that like I said, contact sport, you're hitting somebody else or constantly hitting each other, That's 65%, and around to 30 to 40% of players in that play rugby. So rugby players, also according to Rachel in 2025. The prevalence is unknown since it can differ greatly with the athletes, according to Wahia in 2022. The reason why it was saying that it's kind of like unknown because in some players, like I said, it could have happened something like grade one. That is not that's the most common one, and it can be treated pretty quickly. Patient would not be able to have any type of like grade injury or anything like that, but it can also something happen to to an athlete that instead of having a grade one, the impact was so great, like it was so hard that it could lead to a grade two or a grade three, where it can lead to further injuries in the future and kind of like have some problems with it in the near future. Prognosis can vary, like I said, because it can lead to no greater or permanent damage, but can also have a greater, more long-term damage in the athlete. Kind of like what I just said. If by any chance the injury instead of being a grade one for the stinger is a grade three, then that could be leading further damage in the future for the athlete, even though they're gonna be having surgery in the area. Now I'm gonna be talking about the indications and contraindications. So some indications of leading for stinger will be burning sensation going through the arms to the fingers. Uh, Besides burning sensation, it can also be loss of sensation, so kind of like numbness and tingling in the area that it could lead to that too, or inability to flex or extend the cervical neck. Kind of like the patient is gonna be feeling like really stiff in the neck, like he will not be able to like do any type of extension or rotation of the neck. Sometimes even flexion could be also affected. And then some contraindications will be um, antral antler to axial instability, residual subaxial instability, sagittal malalignment, and neurological deficits, according to McCartney in 2026. Now the healing stage, that's gonna be mainly for like what the study case was for, what the study case was saying. So patient reports that he's feeling a stiff neck and feeling burning, tingling sensation going down to his upper left extremity to all the five fingers. So kind of like the burning sensation from the shoulder all the way down to his fingers. But then after 48 hours, patient reports no symptoms of patient reports no symptoms of before and no abnormalities. I was supposed to write something else over there. It was supposed to say patient shows reports no symptoms after the 48 hours, but before that, he was receiving some abnormalities like the burning sensation towards his fingers because the patient was doing some activity. So patient was reporting the burning sensation, but it was because of a recent activity that he was doing. During the activity was the moment that he was feeling that sensation. Um, Patient also reports that tingling sensation has been feeling it before during a year for at least a dozen times, and every time it happened with a collision in the sport. So, like I said before, patient has been having previous injuries for a whole year of related with stingers and burners, and the sensation that he was having at the moment, it was kind of like really similar to around a dozen times that he was doing that. And then from the healing stage, seeing how the process is and how the patient is doing, I will say that patient is currently in the active phase, kind of like in that moment to increase range of motion, increase muscle strength, but not go too many advance in that. In this healing stage, we're going to be focused, like I said, decrease pain, like the burning sensation the patient has been having, and increase the range of motion of the patient. Then comprehensive plan. Patient currently reports limited range of motion of 10 degrees in neck extension with no pain. Patient reports also 45 degrees of rotation of the neck with no pain. Normal limits with neck flexion. It's also reporting no motor sensory deficits with dermatomes and myotomes. Reflexes are equally bilateral. Some slightly, not slightly, but it's having some hypertrophy in the left side shoulder with spams and trigger points. Um, Also, a patient was reported to the radiologist when he was into the ER. Report says from the radiologist shows decrease in cervical lordosis curvature in the neutral lateral view. So, cervical lordosis means that patient will be kind of like rounded forward. So, kind of like neck is going forward, including with the shoulders. Best instrument to recognize and follow up procedures of how the treatment is going to be, of how the treatment is going. It will be visual, lateral visual, to recognize if the patient still have the cervical lordosis, and a goniometer to evaluate the range of motion of the patient. Those are gonna be like the best instruments for that. And physician order is to rehabilitate the cervical. Uh, it will be to start a rehabilitation program to restore the curve of the spine and decrease the compression of the nerves. Now I'm gonna be showing some of the goals. I provided two goals for short term and long terms. So for the short terms, it will be increase the range of motion of cervical extension from 10 degrees to 25 degrees within the next 2 weeks. Or the second short term goal will be also range of motion, that it will be increased range of motion of cervical rotation from 45 degrees to 65 degrees within the next 2 weeks. And then for the long term, it will be increased posture from around the shoulder to normal within the next 2 months. So the way that we can be able to see that will be kind of like with the lateral visual view. And then for the second goal, it wasn't actually saying it on the case study, but because of having those rounded shoulders and that cervical lordosis, things that can be able to lead to that, it will be weakness on the back muscles. So the other goal was increase strength of the trapezius by 70% from initial assessment within the next 2 months. So with the initial assessment that we provide, that we create, like evaluate manual muscle testing, range of motion, and all that stuff. Whatever the manual muscle testing and the strength percentage of those muscles of the trapezius we're gonna be increasing it by 70% from the initial assessment. Now I'm gonna be talking about the assessing the progress. So the way that I'm gonna be assessing this will be to evaluate the athlete for reassessing the clinical findings such as improvement or regress. So really important that we keep an eye on the athlete, see what exactly is happening, see what the exercise is doing, see if there's any kind of like complaints while doing the exercise that he doesn't tell us, or that he might tell us. That is why it's really important to keep an eye on that. Using I was supposed to say there, using a document for this arm, I was gonna say using an arm disability outcome to evaluate the score before and after the starting treatment to evaluate the progress of the athlete. So it's kind of like a patient rated outcome document to evaluate the score of the arm disability, where the patient is going to be showing kind of like the score and going to be talking about the pains, discomfort, if it has any, or any type of those things that are going to be related with the document. And then evaluate visually the performance of the patients, see if there's any discomfort during the rehab or it makes it look too easy in order to advance. Like I said, we're gonna keep an eye on the patient, so if it shows that it's gonna be like really easy, then we can be able to advance to the next step. That will be kind of like either increase strength, increase the repetitions of the exercise that the patient is doing, and all that kind of stuff. And then some red flags that can lead to regress the progress. It will be kind of like reproduction of symptoms again. So it can be either pain, discomfort, or having numbness or tingling again during the activity. When I mean during the activity, it could be like during the exercise or anything like that. For example, he's doing some kind of like Y and T's exercise, and he's having that tingling sensation or burning sensation. Then that means that exercise cannot be able to cannot be done. So we're gonna regress that, and then we're gonna redo whatever the things that we were gonna be doing before that exercise. And then interprofessional team. In my opinion, interprofessional team. So the team that is going to be mainly with the athlete, with the patient, right? Kind of like help him out through the progress will be the AT. AT is mainly going to be doing the rehab at the school with him. So whenever the patient has availability to be able to go to the ATR, that's what we're going to be doing. We're going to be helping the patient doing those exercise to be able to progress for the smart goals and to be able to achieve them. The primary care physician will mainly be kind of like if the patient needs some type of like medications or anything like that, that it will need to be kind of like requested from him, so he can send like the forgot the name in English. I'm sorry. Uh, so the primary care physician can be able to send the documents regarding about the medicine and the medications, the prescribed medications that the patient needs. And then the physical therapist, which is going to be the one observing, the one that uh, did the radiologist, the one that did the X-ray and all that stuff, to be able to see um, the results that lead to the cervical lordosis and all that kind of stuff. That will be the physical therapist job. So all three together can be able to help out the patient, keep every single one of us informed of like how the things are doing, and see if there's any progression or is there any regression that we need to make. And then for the discharge assessment, so that way the patient can be able to go to return to play activity. Will be patient that needs to be reporting no pain, no tingling sensation, or burning in the area. Patient shows and Patient reports and shows visually a change in the posture showing the increase of strength of the back muscles. In that case, for that one, a lot of the times that posture can be able to take a long time to be able to come back. So that will be mainly kind of like not back to normal, the visual change, but there should be kind of like a greatly increased change compared to the initial assessment from the first time. And then full range of motion of the cervical neck, that will be flexion, extension, and the rotation of the neck. And manual muscle testing being a 5 out of 5 on the muscles. That will be for the trapezius, upper trapezius, middle trapezius, rhomboids, and lower trapezius. Now on the next slide, I'm gonna be showing about like the exercise, the 7 to 10 day program for the patient that is gonna be doing. Now over here, first we're gonna start with a warm up aerobic bike for 10 minutes. It's gonna be a light warm up to increase blood flow. That it says according to TLL, it's important to warm up for the bike to increase blood flow in order to reach deeper area in the muscles that can help with the decompression of the nerves. So the increase of blood flow will be able to increase those type of like healing tissues and all that stuff through the blood, right? More nutrients and all that kind of stuff that can be able to help heal the process and help heal the muscles to be able to increase the strength in the area. So by doing so, it helps decrease inflammation of the muscles. And by increasing the inflammation of the muscles, patient is going to be having decompression on the nerves. The other modality exercise that we're going to be doing, it will be cervical bilateral traction. It will be around 4 to 5 sets of 45-second hold with a 1 minute rest in between. So the importance of this is going to be decompressing the muscles and also the nerve roots. So by doing that traction, I'm going to be decompressing that area. I'm going to be decompressing the the cervical spine. I'm gonna be decompressing the nerve roots. I'm also gonna be decompressing the muscles. That is gonna help with the relaxation and increase that range of motion of the athlete. So according to TLL, it's important to decrease the compression that it has in the area to be able to mobilize the hypomobile joints that is causing the stinger. Then the other exercise will be Ys and Ts. That is going to be 4 sets of 10 reps with 1 minute rest, 1 minute rest in between. That minute rest can also be decreased to 30 seconds, but I decided to put a 1 minute rest because I would like to see first how the patient is doing, if there's any type of discomfort, or is there any type of reproduction symptoms going back. So that's why I decided to choose a 1 minute rest. And same for that one. According to TLL, the reason of the stinger can also lead of a bad posture. So it's important to increase the strength of the muscles in order to regain and retain the normal posture with no curvatures. Then the other one will be cervical unilateral traction. Uh, Same thing is going to be traction, but instead of being bilateral, keeping the head still at neutral. I'm just going to be leaning it one side first. I'm going to be doing 4 to 5 sets for 45 seconds with 1 minute rest also. And then after I'm done, I'm going to be doing it on the other side. So that way I can be able to target both sides. I'm just targeting it separately. And for that one, it's going to be the same thing as the cervical. Decompresses the muscle and the nerves in order to alleviate the pain and reduce the tingling. And same thing with tilia. According to TLL, it's important to decrease the compression that it has in the area to be able to mobilize the hypomobile joints that is causing the stinger. And then the other exercise will be upper trapezius stretch. That will be 4 sets of 20-second hold, 30-second rest in between. So it's gonna be kind of like stretching the upper trapezius. You're gonna be leaning the head sideways. You're gonna be looking to the side, and then you're gonna be pushing kind of like downward, so you can be able to stretch that upper trapezius. The consideration and notes: decompression of the muscle that can also help decompress the nerve roots. So by doing that stretch, I'm gonna be relieving and releasing that tension that the upper trapezius has. By releasing that tension, I'm gonna be decompressing those nerve roots. And then according to TLL 2025, the decompression of the muscles can lead to an increase of blood flow and also helps with the nerves since they are not going to be pinching the nerve roots area and helps alleviate that area. So like it helps decrease the pain. And then summary was kind of like similar. I'm going to be talking about what I just said. Patient was a 23-year-old football player, Berners intermittent cervical, showing Berners intermittent cervical pain. Diagnosis, I did not say it before, and I apologize for that, but diagnosis from the radiologist was saying that it's going to be a trapezius spasm and cervical stenosis. Physical therapy will help with the increase of strength and decrease the decompression. And then the goals will be increased range of motion and increased strength on the muscles. And here are going to be my references.